Welcome. I'm Dr. Vinay Prasad. I'm a hematologist-oncologist, and I'm Associate Professor of Medicine at the University of California, San Francisco. In my professional life, I see patients, I teach trainees, and I do research in healthcare policy. This is Plenary Session. Plenary Session is a podcast at the intersection of medicine, oncology, and health policy, and you're listening to Season 3. On this week's episode. This week on Plenary Session, I'm back in the studio with Dr. Monica Gandhi. Something happened. Something deeply unfortunate happened. Monica Gandhi has a lousy surge protector. I blame it on the surge protector because the plug came unplugged and we lost 2 bits of conversation. We have 4 parts to this Plenary Session podcast and 2 have been erased forever. So you get 2 parts. So it is a bit of discontinuous conversation, but I think it's still worth it. It's still quite satisfying. Hope you enjoy. If you like this podcast and want more content, follow me on Twitter at vprasadmdmph. Check out the YouTube channel, Vinay Prasad, MD, MPH. Patreon backers will get access to the slides for lectures I give on Plenary Session. Want to hear from us? Email us your question at plenarysessionpodcast@gmail.com. Okay, we're back. Monica Gandhi just unplugged me.
So we can say lots of things.
So now she's back on the record. So you were saying, you were taking us through, so you knew when you were a Harvard medical student you wanted to do HIV. You came here, obviously, the epicenter of HIV, certainly in the 80s and into the 90s. And then, and you were drawn to underserved populations.
Yes, because I wanted to serve people who are poor, uninsured, and there's a lot of substance use, mental illness in our population at San Francisco General in our HIV clinic, and I was very interested in this population. It's an underserved, vulnerable population that just because these HIV medications are here, there are other things in life besides the ability to take those HIV medications. So I'm very interested in this.
I see. And that has a commonality to your discussions and your talk in COVID, which is that, you're somebody who's obviously an ID doctor, exquisitely concerned about COVID, but you always think about a disease in the broader context of all the challenges people are facing in their lives and all the sort of threats to their health.
Yes, that's exactly right. I am, like you said, very concerned about COVID and its impact and its severity of disease. However, holistically, the 2 things that HIV taught me is that other aspects of life, like poverty, like loneliness, like mental illness, like substance use, everything else that's going on has to be putting into our equation when we talk about COVID. And the second is that it can never be about one thing, because HIV was never about one thing. So we can never just talk about COVID without talking about the totality of someone's life when we message.
Before SARS-CoV-2, before COVID-19, were you active on social media?
No, I was not at all active. I've never been on Facebook or Twitter or anything before SARS-CoV-2. Someone told me I was supposed to get on it during SARS-CoV-2, so I did in April 2020.
So you pretty much joined at the worst moment in time.
Yes.
For discourse.
People can yell at you. Yes.
So I wonder, what was it that compelled you to say, I want to go out here and give my perspective?
Because what happened was 2 things. One is that I wanted to make sure that I got all the up-to-date medical information, and people were saying things were tweeted on Twitter before they even came out in preprint. And the second was that the dialogue seemed really one way from infectious disease doctors, not including this HIV perspective often, or not including holistic aspects of other people's lives and economics and loneliness. And I wanted to talk about that as well and discuss it so that I wouldn't look like I was just talking about one thing, which was only the virus of SARS-CoV-2.
And when was this that you joined?
I joined April 2020.
Wow.
A month after
the first blow, the
Yes.
first shutdown. I see. And I don't know. I mean, I think listeners, I should tell listeners, for the few listeners who may not follow you on Twitter, you're known for offering a very nuanced, deep, rich, and thoughtful portrayal of both the disease we're facing and the responses to it. And you're somebody who I think really brings a different tone to the conversation. Maybe we'll talk about that for a second. So I think one of the things that's different is there are many people who talk a lot about the virus, and the narrative is doom, gloom, fear, even when there's good news. Vaccine comes, but when are we going to get it to people? Okay. But then we get it to people, and then, but variants are coming. And you should not relax any restriction. Of course, not in public, but also not in private. You should not do anything. And every day there's a new doom story. You don't bring that same perspective. You bring a perspective that's balanced. I mean, I think some will label you as an optimist, but I think you're neither an optimist nor a pessimist. You're just really balanced. It's just that in comparison to doom and gloom, you look like a raging optimist. So I wonder if you might talk about that. I mean, this is just who you are. You're not trying to do anything, I would imagine. But why do you find yourself in this spot?
Because I can't believe that the pandemic was declared by the WHO on March 11th, and that November 9th, we all woke up in the morning and we had the first vaccine news on a press release from Pfizer. And I can't believe we're not like literally jumping up and down all day long, because these will get us out of the pandemic. They always have before. It's about severity of disease and not what's in your nose. It always has been about severity of disease. Otherwise, we never would have had people wear masks or shut down society or care about this virus. We wouldn't be testing everyone like crazy. None of this would ever happen. It's all about severity of disease. And all the vaccines incredibly protect against severity of disease. And so all we should be thinking about is how amazing it is that we got the technology in these vaccines. We have like 7 that we haven't approved, by the way, but and we should get those out quickly. And there's nothing else to talk about because we need to get through this pandemic. We can't afford to have schools closed. We can't afford to have people lose their life savings because then they'll die of hunger and other things. It is imperative to just talk about how great everything is at the moment. And I don't understand. I truly, genuinely, in a wide-eyed, I'm not being cynical, I don't understand why we're still doom and glooming messaging. And I don't understand why after we're vaccinated, we can't get back to human closeness because loneliness is profoundly wrong. It is against our very primate nature. So I'm not even tweeting like cynically. I'm just literally saying I don't understand. So let's talk about the greatness of where we are right now in this pandemic.
That's a very, astute point you make. I think a lot of people may not be ready to hear it, but it's a real point, which is that if you had SARS-CoV-2, same virus, and if it did not result in a fraction of people being hospitalized, if it didn't result in a fraction of people suffering respiratory distress, if it didn't result in, half of 1%, less than 1% of people, I don't want to say exactly the number because it's going to get me in trouble, but some tiny fraction of people dying, if it didn't have that, would it be fair to say it would just be another cold?
Well, exactly. So what happened in the end of 2019 is that there was a whistleblower event in China, and then the WHO was alerted that there was this virus that was causing terrible acute respiratory distress syndrome. And then it ended up resembling a virus that causes colds, which are coronaviruses. But that alert never would have gone out. It never even would have been brought to our attention if it didn't cause severe disease at a higher frequency of other coronaviruses or rhinoviruses. And so it is that very thing that we have to take away from this virus by generating T-cell immune responses in all of our bodies so that no matter what's happening in our noses or it doesn't matter what we need to take away from it. It's its ability to get into our lungs and cause severe disease.
And I think that's, so important because if you start to conceptualize it that way, which is if it were not for the severe lung disease, you wouldn't even have a label on it. It would just be one of the many things on that 8-plex panel that we send on people who complain of URI.
Right.
The reason that's important is it appears from 70,000 persons pooled in vaccine studies that there is, and correct me if I'm wrong, you say that in your grand rounds you pointed out 1 hospitalization, 0 deaths from COVID-19, and 70,000 people vaccinated with a number of different vaccine products.
That's correct. So now there are 7 phase 3 clinical trial results that are out there. I just added the Sinopharm one this morning to this table I'm making, and there was one person hospitalized who didn't die who got the vaccine.
I see.
And otherwise 0 people hospitalized, 0 in all the vaccine trials who got vaccinated, compared to many that got hospitalized who received placebo. It is astounding. It is incredible. This is all we should be focusing on. And it leads to so much optimism. I'm still happy even though schools aren't open and all these other things, because it makes me so sad that we can't take that optimism and run with it. And this is against variants, by the way. So keep in mind the Johnson & Johnson vaccine was studied when 95% of the variants circulating in South Africa were the B1351, the one with the E484K mutation, the one that we keep on talking about. That vaccine, that very virus was studied, and still severe disease was curtailed massively.
And that's important, which is that, the doom and gloom messaging is that it was, I forget the precise number, but 60 or 70% effective against symptomatic COVID. But the right way to look at it is it still appears to be exquisitely effective against the thing you're worried about, bad COVID.
Correct. Exactly right. So mild COVID, as you know, can range from a stuffy nose to 0 symptoms at all. There is an estimate from the CDC, which I agree with, that 40% are completely asymptomatic, only just had it in their nose, who never would have known about it if we hadn't happened to PCR their nose swab. So if you feel completely well, those are also not the people who come to medical attention for having longer term symptoms. So yes, I think it will defang, as I say, the virus completely. And that's what measles vaccine did. That's what mumps, that's what rubella, that's what pertussis, that's what they all did. We just never swabbed people's noses because we didn't have the technology to do PCR in the 1800s for measles. So we never did it. People could have been holding it in their nose the entire time. But the output of all the trials for all the vaccines are what happens to severe disease. And we got it with these COVID vaccines. Spike protein works.
Now, there's some people who are concerned that you could remove the severe disease, still acquire even an asymptomatic or a mild COVID infection, like a runny nose, and then, without having the severe disease, develop long COVID complications, cardiac damage, lung damage, other long COVID complications. Is this, I don't know, what are your thoughts on this? Is it plausible, possible? I mean, I guess it's within the realm of possibility. Is it plausible? Is it likely?
It's not plausible that what really causes longer symptoms after an infection is having a massive innate inflammatory response. Not the adaptive one, but the innate non-specific inflammatory response. And so it's people who have been brought to medical attention because they got sick. Then they knew they got COVID. They had a diagnostic test for COVID, and then they can feel unwell for a while after, usually because they had symptomatic COVID. We don't have great data on this. We'll get more data out of UCSF. They're going to publish a paper that it's severe and moderate disease that leads to longer symptoms. So if you've had asymptomatic infection, it doesn't trigger the inflammatory pathways to lead you to not have longer term symptoms. So it doesn't biologically make sense that you could have asymptomatic COVID and then feel unwell 8 months from now.
That's, of course, my bias. I think it doesn't make a lot of sense. But it is something that people say, which makes me wonder that they've run out of doom and gloom things to say, so they have to resort to this new doom and gloom.
Yes, this is my concern, is that I sort of think about it this way. There are a lot of people who in high school, like, no one really talked to them because they were in the lab, and they're really geeky and stuff, and that's fine, that's great. And then now they're talked to all the time on TV, and they get to give interviews, and this is kind of interesting. You get to be like a lab person, but you get to talk on TV, and you don't even go and see patients because you're just in the lab. And I'm getting concerned that the doom and gloom messaging is a hook, unlike people like to be on TV. There's no point to do this doom and gloom now. There's 0 point. We have great vaccines. All we should be focusing on, keep on thinking, anyone who wants to give a doom and gloom interview about the variants should actually put their mask on, go down to a mass vaccination site, and volunteer to log in people, because what we should be doing is vaccinating people as much as we can.
I think that, you broach a topic that I spent some time thinking about, but I don't think I fully have wrapped my head around what's going on. I agree with your observation, which is that there are a bunch of people They, I think, have two main forums. One is the nighttime cable TV forum. The other forum is Twitter, which is a reinforcing forum because you're constantly getting a response for what you're putting out there, which is likes and retweets and that kind of thing. And if people are afraid, which I think many people are, and there's a huge contingency of afraid people who are on the website, and you keep putting out fearful doom messages, you're going to continue to hit that feedback loop. And then I think it's very difficult to shift and pivot to a realistic appraisal of that it's not how it was last year. We have a vaccine, 7 vaccines.
7.
And they're all amazing.
All amazing. All
amazing. I'm so shocked.
I'm so excited. It's this technical, I don't know. I mean, we were poised to do it. If you have a pandemic in the 21st century, I think you can make vaccines fast instead of after the fact in the 1918 influenza pandemic. But yes, what I learned actually from an interview that someone I did with is I watched an addiction specialist and explain the process of fear and how addictive it is, because it really makes sense, because if you want to run away from the saber-toothed tiger, it is very adaptive to be fearful.
I see.
And so we do get addicted to fear and to doom, but we need to unhook ourselves from that fear and doom and concentrate on getting these vaccines out quickly, because by definition, all of this fear will melt away when we see people like we're seeing in Israel, what we're seeing in to the UK to a certain extent, when we see people stop going into the hospital for COVID-19, the fear will by definition go away, because that's what scares us, is getting ill. That's the only thing that scares us.
If 4 people have been vaccinated and they want to have lunch together, what would you tell them?
I would say please have lunch together. So wait for 10 to 14 days after your second vaccination. Then you're not only 90, with the ones we have here, you're 95% protected against illness, even mild illness. So that's the important thing. The couple of people who got ill from COVID had very mild illness in the vaccine arm, but probably before they were 100% protected, which 2 doses did for you. And so you're not going to be spreading it. You're lonely. It's been a long time, and you should have lunch together. And I think that is really important too, because I bet once we start seeing each other more, I bet anything that some of our fear will melt away, because it is partially the social isolation and how unnatural this is that has led to an addiction to doom and gloom.
Oh, that's well put. Schools. Let's talk about schools for a minute. You've been somebody who has been willing to say it. Schools need to be open. The kids need to be there. The risk of the kids are low. We learned early on the steep age gradient, unprecedentedly steep age gradient, and kids remarkably are doing well from the virus, but they're not doing well at home. There's a lot of anxiety, a lot of depression. I've seen some different conflicting reports, and somebody says, well, there's no increase in teen suicides. And I say, well, that's a late marker of the fact kids are suffering.
That's as bad as it can get.
Yeah, that's as bad as it can get. So, you don't have to wait for an excess of kids killing themselves, which, by the way, they'd have to be killing themselves in environments where everyone is trapped in the same tiny area, which might be, they might be suffering as much as someone who kills himself, but not actually able to kill themselves because they're around a lot of people in a close quarters. But my point is that's not the that's not the end point.
Like, you don't want to wait for severe COVID disease.
Yeah. Just like you don't want to wait for severe COVID, you don't want to wait for suicide to know that people are anguishing. They're suffering. Kids are suffering. They're not learning. I mean, there's a number of studies that show educational outcomes are poor. Education is one of the few. This country, how many upward ladders do we have for opportunity anymore? We've ripped them all down. We have one ladder, and that ladder is K through 12 education. That's the only ladder. And we've taken it away for a year. What are your thoughts on schools? And then maybe some specifics. Should there be distancing between individual kids, or can we distance a cohort? If a kid tests positive, do you quarantine the class for how long? What are your thoughts on these questions?
Yeah, I mean, the one thing I will say about myself is that schools, I have never said should be closed, even from March on. And I will always look back and say, I know I said the right thing.
Yeah.
It's just no one was talking to me back then. We weren't talking, so I would just say it to myself. And the reason is that actually quite quickly, but okay, so the initial reason was right, that children don't get so ill from COVID, thank God. And then the second reason was that very quickly, it was probably end of March, So really quickly, we knew how the virus was transmitted. Wow, like we got that information so fast. So not through surfaces, not through hands. So really three things, that it is through the respiratory tract. And we knew the three things that helped: mask, distancing, ventilation to a certain degree. And you didn't have to have all of them perfect either. Like you didn't have to have ventilation perfect if you were more distant. You didn't have to have distance perfect if you could open the window. You didn't have to have masks be double masking if you had more distancing.
Right,
so
I see.
It was putting those three together. I have a paper coming out just next week about a company that did this. They never closed. They never closed. They just did all these three things,
right.
And no one got sick. No one got sick.
Right.
And these are all adults, of course. But why? Because all these three things work. So no, the distancing does not have to be 6 feet. There's no science behind that. The WHO says 1 meter, and that is actually 3.28 feet. And then someone apparently miscalculated and called it 6 here. I literally heard that.
That's the origin of the 6?
That was the origins, that we had a metric issue like we always have.
Typical.
And so everywhere around the world, there are signs stay 1 meter apart, which is 3.2 something. And then so it doesn't have to be 6. Children can be closer together. And then I do agree with the teacher being further apart, but usually teachers are more separated from the children, so they can have that 6 foot distancing. They can open a window for the ventilation, and if they can't open a window, even though beyond a super ventilation system, opening windows is pretty low tech. Right. They can also wear a more protective mask, and a fitted in more filtrated mask. All of that could be done, and we could have kept schools open because all of these other effects are devastating. So it's going back to that issue, right? Like, when you just take one virus in isolation, that's like isolating a virus in a laboratory. But we're not a laboratory. We're a world, and we're human beings, and children needed to go to school, and we acted like we just had the virus in isolation, and we're like in a sealed laboratory without all these other aspects of life. And if we had just opened also when the incidence was lower, like things would have we would have shown each other that it would have all been fine, because places that did are kept open, and they're all doing great. So the West Coast has been more notable, clearly, in keeping their schools closed. It'll be a big failure of the West Coast. So I keep on thinking, 3 mitigation procedures. Don't shut down society anymore. No more shutdowns. No more shutdowns. So open the museums and open the schools and everything right now with these 3 mitigation procedures. And they don't have to be top notch. They don't need to have the ventilation system all installed.
I see.
Opening a window is ventilation.
And being a little bit better in one gives you some flexibility in the other.
Exactly. So if you don't have a great ventilation system, or you literally can't open the window, which I still think over the summer we should have figured out how to open those windows that we can't open.
Right.
Then wear a more fit and filtrated mask. So they're all pushing and pulling on each other. The triangle, mask, distancing, ventilation, they all pull on each other. Mask can be better if distancing is 3 feet or 2 feet. And then distancing better, you can wear a less fitted mask. It's simple. They all 3 pull on each other. We have a paper coming out tomorrow on this.
I look forward to it. And I mean, it sounds to me like, if I were to just sort of reflect on your philosophy, I mean, you're a pragmatist.
Yes.
Yeah.
That's a good way to put it.
Yeah.
Yes.
And you're a pragmatist because you practiced for many years taking care of infectious disease, people who happen to have an infectious disease, but also have all of the things that happen in life.
Yes. They've been living with it. Yes.
They've been living with it. And they live with other things, like they can't make their rent, or they have drug addiction, or they have some other trauma in their life. And when you work under these conditions, these aren't laboratory conditions, you're not pipetting all day with perfect measurements. When you work in the real world with real people, you become a pragmatist.
That's exactly what it is. It's because the other great viral pandemic of our day is still raging, it's still happening, and people who sit with HIV patients every day, there's an infectious disease, and then there's everything else, and you balance all of it.
I wonder how you feel about this, that some of the people reading these data are people who don't also spend time in the clinic. And one of the things the clinic will always give you is, at the end of the day, no matter how complex or convoluted the data is, you're going to have to tell people answers to binary questions like, doctor, can I do X, Y, or Z? And you have to draw upon all these different types of evidence. You have to understand and be, I think, sympathetic and empathetic to the patient's desires and needs. And then you got to give advice. And the advice can't be, well, I don't know with 100% certainty for everything, because then the patient's going to be angry with you, because that's not really great.
Right. That's a very good point. I have been thinking a lot about this, that and I hope I don't get anyone mad at me, but the PhD epidemiologists who have informed this pandemic have a completely different message, and it seems like they have a completely different way of thinking about things than an MD who sits in front of patients. And so I think you're exactly right that the reason that you don't actually need to be infectious disease trained, I think it is the doctors during this pandemic who have had more nuanced messages, because not only do they have to tell a patient, I've never in my life told a patient the p-value in a paper that it can't be 100% certain. I say, you know what, I actually think this blood pressure medication is really going to work.
Right.
And so you're right. So I think that the MDs that are informing this public questions right now seem to have a different way of not only synthesizing information, but communicating it to the public that allows for the complexities of a human being, as opposed to just a huge faceless population.
Yeah,
and we also have been leaving our houses and going and seeing people in the clinic. And maybe if you're home all the time, you get too abstract.
That's an interesting point. I hadn't thought about that, but you're right. As you know, I switched jobs right in the beginning of the pandemic,
yes.
And my clinic wasn't able to start until I got my California medical license, and that's just because of the delay goes with licensing. But I pushed on them really hard to get it to start,
yes.
and I felt psychologically a big difference when I got back in the clinic.
Yeah,
big difference.
Yeah, you're sitting in front of someone you have to explain, and what do you have to explain? You have to explain COVID, because that's what's going on right now. And so yesterday I had to talk to someone about why I want them to take the vaccine, and I took all of their hesitancies, and I took all of the historical aspects of being African American in this society, and we put together the data, and I went over it, and they wanted to take the vaccine. But it was a conversation that took a while, and it was human.
That is, really, really, really good to hear. And I'm guessing you didn't lead with after vaccination, nothing changes.
No.
That's your opening gambit.
In fact, I said, actually, when you're vaccinated, I just can't wait to hug you, Mr. Because I used to hug my patients like many of people do in the HIV world. I don't know about oncology.
No,
but
oncology is it's a common thing.
Yeah.
No, it's common. I mean, because people come to love. I mean, think of you as almost a part of the family. Yeah.
Yes, exactly. And so... And so it's very human to be a doctor, and it's very touchy, and it's very laying hands on and examining people, and I can't, I think we all can't wait to be doctors and patients together again.
I wonder if you might get into the issue of schools. Hot button issue, obviously. You were, I think, all along on the side of doing, I think you touched about this in the first part of the podcast, which I'm trying to remember. You were always somebody talking about mitigating risk, but it became very clear early on in the spring of last year that the risk to children themselves is, dare I say, on par with seasonal influenza.
Yes.
Dare I say it?
Yes.
It is, and with that knowledge, knowing that for many years we do take that risk, seasonal influenza risk, when we send kids to school every winter, but we do that because we believe. And we know that kids need school for social development, for educational development, for upward mobility, for all these good things. I wonder if you might talk about, how do you view the schools right now? CDC has guidance saying, guidance that basically will put 90% of this country in the red zone, which is hybrid at best for young kids, and, almost nothing in person for older kids unless they're actively tested. What are your thoughts on 6 feet of distance? How do you think about these tricky issues?
Yeah, I think there's 3 things that concern me about the CDC guidelines, and I mean concerning that they can bring the whole thing to a halt. So one is this question, like you just said, it should be immaterial what community incidence or transmission or prevalence is, all 3 of those, because of their own data from Wisconsin and North Carolina that they published in their own journal, the MMWR, that, even in areas where there was high incidence, that you can keep people safe. It's actually the same reason. Did you know that UCSF just published, they didn't publish it, but they gave a talk that occupationally at UCSF, the people who are out at home working, as opposed to us who are sitting here, they have more COVID than we do.
Is that true?
Yeah,
I haven't
it's
seen
true.
that.
And I tweeted it, but I'll send you I'll send you the link that because why? Because all we do as we're sitting here, if we're not vaccinated, is mitigate risk. All we do is mass distancing, ventilation, the three triangles, and we don't like what ventilation? Like the windows cracked open, and that's ventilation. So, so because of that, we've had very little. Once we instituted those three components, we have very little COVID-19 transmission in our workplace, and there's more out of our employees who are sitting at home. So the same thing with schools, that has just been shown again and again. Germany, there was this amazing article yesterday. They opened really high incidence, and they believe, I think, in cracking windows. Apparently, the windows were just a little bit open. Fresh air is a good thing, and so they didn't even actually wear masks, the children, until in November. No transmission to teachers from students at all. It was the opposite, if anything happened. So that's one concern, that they shouldn't have put community transmission in the level as in their guidelines when their own data said otherwise. Second is distancing. No magic about distancing, as we talked about, right? The meter. The rest of the world is a meter, or at least anyone who's going by WHO guidelines, which is 3.28 feet, I think. So no 6 feet business. And certainly the CDC just put guidelines out that if you want to, if you have less distance or there's something that's more concerning, then you fit and filter your mask more. So you tighten your mask and you can have a better mask fit. So I would advise that teachers who are inside who are not yet vaccinated, if there's not 6 feet, to have a better mask. And then the third thing that concerned me was that it was kind of vague on testing and screening. There's been no setting that's shown that changes anything to test and screen. And so I think they should have just left it kind of up to the district how you want to test and screen, because, as you know, the quarantines, universal precautions by definition means you think everyone has COVID. Why would I mask around someone who's tested every day? Then I'd be on Saturday Night Live and we would act, and we because those guys are hugging and acting all over the place because they test all the time.
Right.
So if you don't test, what you do is you presume that everyone has COVID, you mass distance ventilate, and that's how you don't need to test, and that's why we've never tested routinely in healthcare settings. We just come to work. So those are my three concerns about the CDC guidelines.
And I think those are really terrific, and I've traced a couple of them. I tried to get to the bottom of their relationship between community levels and what schools should be doing, and it took me to sort of a Lancet Infectious Disease paper that ran a number of analyses. This was done in the UK, I think, between July and August of last year, and the analyses were basically the x-axis was cases by day, not by 7 days. So they've actually kind of changed a little bit per 100,000. And the y-axis were the number of cases that they could contact trace, like to school spread, and the number of outbreaks, which were defined as more than 2 cases. And there was no statistical relationship, as you point out, between cases and the community spread, that it really had to do with what they were doing in schools. And there was a statistical relationship between outbreaks, quote unquote outbreaks, and the population levels. But if you look at this regression, it's just terrible. It's like 3 data points driving the whole thing. It's a sparse thing, and the absolute risks were 0.2% for outbreaks in all these schools. That's by school, and by people, I think it's like 0.04% in terms of actual number of people, kids or teachers who got infected. This is really threadbare data, and that is what their report links to and cites.
Wow.
Yeah, so I chased it down a little bit.
Wow, that was good to do. That's yeah. So
it's
we're not the holistic aspect like we talked about last time. We don't want people to actually kill themselves, right? Like we want to head off those things in the past, and things are not going well for children. Yeah,
I wonder if you might talk about that. I mean, I've heard from a number of my colleagues, mostly colleagues who have sort of teenage kids, that it's a tough time for teenage kids. I've also been reading the many reports about anxiety, depression. I think, that I mean, you've said that a couple times. I guess this is something that I think will be different to some people, because some people say that how does one weigh a life against anxiety? Anxiety you can get over. A life is a life. Once it's gone, it's gone. And I think you're somebody who, I don't know, I wonder how you put it. I mean, you're sensitive. I mean, obviously you're a doctor and you don't want anyone to pass away of COVID if it can be avoided.
Definitely not, yeah.
Yeah. But you're also somebody who understands that mental anguish is terrible. And it is, I mean, there are people who suffer deeply while alive, and the fact that their heart happens to be beating does not mean they're suffering any less. So how do you weigh these things?
I think it is like what we talked about last time. Because I'm an HIV doctor, through and through, it isn't just about the risk of one thing, which is the HIV in their body, because we haven't cured HIV, so that's still in the body. It is HIV in the body and then all the other elements of that human. So then if you actually extend that to society, then you think, okay, so there is a terrible pathogen out there. Luckily, we have these amazing vaccines. We're going to get through it. But there's this terrible pathogen out there. It has led to many deaths and lives being taken. So how do we take that pathogen, considering all of population as one human body in a way, and saying, okay, how do we minimize the damage from COVID and also take care of society? And so now this far into the pandemic, we can realize one thing that we did not take care of at all was children in our society, or at least children in the places where schools weren't open, because I think there's clearly some schools that are open in the United States. So then you think of the whole organism and you think, okay, I have to mitigate risk, do whatever I can to ensure that teachers are safe, whatever I can. Oh, wait, it's a respiratory virus. I know how to keep them safe. I know it. I know it from not just data, but I knew it in March from the fact that it only goes from the nose and mouth, and it's not fomites, and it's not transmission, and it's not radioactive, and it's not a mystery. We knew it in March. And so actually it was February that the New England Journal papers were coming out about masking and asymptomatic transmission. So we know how to keep people safe. So then we know how to assume everyone has COVID because we're making all that assumption, and we know what techniques to apply to mitigate risk. And one technique is to keep everyone at home. That is the worst technique of all, because that technique has just completely failed to consider the entire society as one organism. And then you ensure that you mitigate everyone's risk and still take care of other elements of society. I'm not understanding that this late into it that we're still saying that we don't know how to change risk, because we do. We're not even remotely in March 2020.
The companies have announced, and some even ahead of schedule, that we're going to get a lot more vaccines. We might even be in a situation by June that any adult who wants one can get one, be vaccinated. And of course, I'm sure you're the biggest proponent that they ought to do that. My question is, where do you see the next stage? We're getting the seasonality effect. The cases are plummeting. We're going to get more and more vaccinations. The summer, I'm hoping the summer is going to be great. Everyone who wants one will be able to get one by then. And then the questions I have for you are, some people are saying that the kids will need one vaccine as well. Your thoughts on that? What will the fall look like? Will there be potentially some small outbreaks? What will next year's fall look like? I mean, is this a virus that's going to be with us? What are your thoughts on these questions?
Yeah, I think the virus could still be with us, but it totally doesn't matter, because if the virus is still with us, just like rhinovirus is still with us, as long as it just causes a cold, then no one cares. And in fact, we shouldn't even be screening for it. So that's what vaccines will do, is it will render the virus without the ability to hurt people. It will render it that they don't get hospitalized, they don't get sick. So and you don't actually need every single person to take the vaccine to do that. So by definition, this is what I think will happen. When very few people are in the hospital because of this specific illness, not maybe no one, but a few. So let's take big cities in Delhi. What happened is that, or big cities in India, sorry, when no one is needing a ventilator, when no one's in the hospital, literally society flies open. It's just by definition. And so if people aren't getting sick from COVID to any alarming degree, if it's one more thing that you manage in the hospital for a few people, just like you did influenza, then there will be no way to keep society from not being open. I know that many people still try to talk about that. We shouldn't have movies and theaters and all the other things, but it will not be possible because all the other aspects of life will flood back in when this isn't scary. And so we don't even have to argue about when to lift restrictions. It will happen.
Really?
You
just think people will vote with their feet?
Yes, they will, because people are only frightened right now and masking, distancing, staying home because there is a disease out there that can make them ill. And if enough people get vaccinated, then their T-cell responses are primed. So even if they see it in their nose, the T-cells will come out and they will prevent you from getting severely ill. And the hospitalizations will melt away as they have in Israel, as they're starting, almost, not even starting, they're really happening in the UK. I think there was 238 deaths 4 days ago. And as that happens, people will stop feeling fear. It's a natural response to feel fear when you can be hurt, and it's a natural response to not feel fear when you can't be hurt. And it will happen. And yes, I think that we're going to have a good summer. If all these vaccines, if we get enough people we have enough vaccine supply and everyone who wants to get it gets it, we're going to have a very good summer.
And children vaccination, your thoughts?
Not necessary, because they are not the ones who get ill. Very thankfully, bizarre aspect of this virus. And so not necessary for them to be back in school. Teachers won't be able to pass it to them with their fully vaccinated status. Teachers won't get it from them because they're fully vaccinated. And so teachers will be perfectly safe once they're vaccinated. So there's no issue for teachers to feel safe if children aren't vaccinated, and children, when the trials are done, they can get vaccinated if their parents choose to. It's going to be a risk-benefit analysis depending on the side effects of the vaccines.
That's well put. In the winter of, let's say, 2023, maybe lots of people have been vaccinated. Your thoughts on will we need a seasonal booster? Your thoughts on will you hear about a nursing home in North Dakota that had an outbreak of COVID, winters from a few years from now?
I actually don't think so. So I think it'll be still circulating, and it'll probably be put in a respiratory viral antigen panel, like when people come in and they get sick.
Right.
And so when people come in the hospital, people may not know this, but we actually screen them for something as minor as rhinovirus by, swabbing their nose and doing a whole panel. Not because we can actually have treatments for rhinovirus, but because we just want to know why they got sick. And it's possible that SARS-CoV-2 will be added to that mix. And because they have the T cells that are so long lasting, at least, and I always point to this Jennifer Dan UCSD paper in Science, that the T cell half-lives after natural infection, which will simulate vaccination, look like they have a half-life of the yellow fever vaccination, which is a once-in-a-lifetime vaccine, unless you're in a high-prevalence area, and then you'll need a booster. And so it doesn't look like it's like going to wane that fast with T cell immunity. So, and then couple on top of it that SARS-CoV-2, the very polymerase that it uses, does not have a high mutational rate. It actually has a better proofreading mechanism, way better than influenza, way better than the reverse transcriptase of HIV. So it looks like it's mutating. It's not. I mean, it's mutating, but it's what it does, and there's a lot of cases right now. Once we tamp down transmission, it won't have this chance to go forth and mutate like this. And so I think it'll be one other respiratory virus that we screen for. We do have treatments because we spent all this time treating someone who comes in with severe disease. They will get remdesivir and steroids in this setting. In other places, they'll get steroids. But it won't be very much because hopefully we will have reached enough of the population being immunized. Even people who don't want to take the vaccine now, they'll feel good about the vaccine in a year because they'll say, hey, everyone took it and they didn't have serious side effects. Okay, I'm feeling better about it. I'm going to take my vaccine next year. And we'll eventually get more and more people taking the vaccine. It can always be updated if it needs to be for some variant, but I do believe from what I wouldn't have said this even 6 weeks ago, but what I'm seeing in Israel and the UK, it's real world data. It's amazing, plummeting. There's like 4 people in the hospital in all of Israel who's had the vaccine.
That's well put. One question that I had about was the transmissibility. I was spending some time digging into this data of the variants, and obviously people say that they're more transmissible. That sounds frightening. But one thing I was thinking about, let's just say there's 2 strains of COVID, A and B, and they both have exactly the same rate of infectivity, 10%, 10%. We know that doesn't mean every single person has a precisely 10% chance. It's a stochastic event that some people are going to spread it more than other people. It just happens to be based on a situation they may find themselves in, etc. It's possible that, if there are two strains, A and B, and they're both undergoing this random process, that by chance alone, one will come to dominate in a short period of time. And then if you look at that exact same data in retrospect and you ask, was A more transmissible than B? Of course, if it came to dominate, it will always look more transmissible in that retrospective data.
Yeah.
Even if they have the exact same probability of spreading. And so I was thinking that, how will you actually, scientifically test that question? And I guess the only answer I can think of is you have to look at A and B in a different data set entirely, different country, different nation, different period of time, or do laboratory evidence to show that there's something mechanistic that makes sense, like it binds the receptor tightly or at lower concentration, etc. But I worry that at least some of what we're hearing about transmissibility is just this stochastic thing. So anyway, I just wonder, how do you...
I totally agree with that.
Okay, yeah.
Yeah, I mean, in fact, if you think about the UK right now,
right.
Somehow today there was still a news article that said B117, so-called UK variant, will dominate. We're going to have another surge with that. But they're vaccinating extremely high rate. They're doing a great job because they chose to have the adenovirus DNA vaccines along with their mRNA vaccines, which I think is a very key element to vaccinating more quickly. And especially if you get one of each, it seems like that really actually helps increase immunity. And so B117 would be having another surge if there was any question. But you have the vaccines working. Yes, every strain right now, because of that stochastic event, the one that took over is B117. It doesn't matter. They're not having another surge. They're just going so low. So anytime you start to get depressed in your mind, keep on pulling yourself back to the real world data. I want to feel doom. I want to feel fear. We're never going to get out of this. Wait, the data is right there. It's right in front of your eyes. It's playing out on the world stage. This is amazing. We've never been in a situation where you get to see things playing out on the world stage. Remember how every other disease, the vaccine was developed many years after the disease got through society.
Right.
I think I was looking back. 1948 was the first influenza vaccine. I have to remember if that's exactly right. 30 years after the
and I think
1918
the fastest
pandemic.
was ever 3. The fastest vaccine was in 3 years or
Once
something.
the thing had calmed down by itself, by natural immunity. You don't want people to die by natural immunity. I mean, there's no other situation in the entire universe where you've gotten the vaccines coming out at the same time.
That's
the cases
an interesting
are still
point.
going.
You're right. Yeah.
And we are watching, instead of a natural surge with natural immunity and then a slower tapering off, we're looking at the incidence go down in a sharp inflection point because vaccines are contributing. Even in the United States, where we haven't done a better job with our vaccine rollout, it's not going down with that natural slow curve. It's actually going down more sharply, even with 65 million people vaccinated and counting.
Now, what happened with India? India it's an amazing thing, but what happened? What are your thoughts on this?
I mean, I think 5 things. Okay, these are my ideas. I don't know, but I don't know really, but 5 ideas, right? So, and many people have said this, but so right now, like you said, India, no one's in the hospital from COVID, and so by definition, society flew open. By definition, few people in the hospital. I think there literally is 2 in all of Delhi the other day. So younger population, that's been said, right? It's not an obese population, so fewer comorbidities. Third is that I do believe that these circulating other coronaviruses, because we keep ourselves very cold free here and we get nervous here, and India there's more people and you get a lot more colds, and so these other 4 circulating coronaviruses, you get natural T cell immunity to them, and that has cross-reactivity against SARS-CoV-2. Number 4, I actually think the simplest thing in the world of all the interventions that you could do is that people could pull up their dupatta and they could put something over their face. And so I think it didn't block all of transmission, but I actually think it blocked them from getting severe illness, and they may have had a lower viral inoculum, and they had asymptomatic infection, which also led to T cell immunity. And then the final thing is herd immunity, both from illness and from asymptomatic infection. And all of that led to what happened in India, and I'm glad they're getting vaccinated because it's another booster. They have their own vaccine, which is a spike protein vaccine, so I know it's going to work even though the phase 3 clinical trials haven't been released. Mm-hmm. And they also have the AstraZeneca, so I'm very glad they're vaccinating. It's another booster because if you had asymptomatic infection, it'd be nice to have a booster, but herd immunity got them through it.
That's a lot of food for thought. But I think, I think it's going to be really interesting to delve deep. I enjoyed you tweeted about it. I enjoyed reading that and thinking about it, and I think you're very likely to be vindicated on a lot of
They just opened schools, though.
Yeah, they just
One thing as a sadness there is that weddings and all this stuff. I mean, because society flies open,
right?
So weddings were having and all these big gatherings and all this, but the schools are just being open now, and the way they're opening is because the government has. The government schools, if a teacher doesn't come back, they have told they can't. They're sacked. Actually,
I see. That's something that doesn't happen here.
no. India's a whole other system.
It's a whole other system. Okay, so here's what I wanted to. I know our time is running out, but I wanted to ask you. And I love talking with you because you're like me. You speak quickly, and I love that because that's how I'm wired. Okay, here's my question for you, Monica Gandhi. You're a professor of medicine. You've been in this business a long time. You've been in academic medicine. You're a distinguished scholar. Everyone I know in infectious disease knows of your work. That goes without saying when people call me up. Which it turns out that sometimes people ask me like, where do you talk to all these people? Like, people actually call me and we talk on the phone and things like that. So I have a lot of ID friends, and they call me and they talk and then they're, always very impressed by your research work. You're a clinician. You've worked for many years. I think it would be fair to say that most of your career, nobody said anything mean about you. Nobody said anything. Yeah.
No one ever yelled. I was the most uncontroversial person.
That's what I want to get at. Yeah, like your whole nobody. Like 20 years, not a single negative word,
not a single negative word,
and I don't know this to be true, but I would imagine that you're the kind of person who got good grades all throughout.
Yes.
You didn't have a bad report, not since you were like since you're kindergartner to now to present day, not a negative peep.
Yes.
So my question is, and then of course now there are a few. I know you're about to run. Okay, there are a few negative peeps, and the negative peeps come on Twitter. Negative tweeps or whatever they call themselves. I guess I want to know, like, how do you, and I think that phenomenon is also part of the reason why that, you can't name that doctor who calls it special kind of pessimism, and also why there's so many ID doctors who I talk to who are in the clinic every day and they're like, what is going on with this messaging? What are we doing?
Yeah.
And these are left of center, progressive, ID doctors,
yes.
Critical care doctors,
yes.
pulmonologists, oncologists. I mean, all these specialties are calling me and they're like, what the hell? And then, so I guess my question to you
they
is...
They should speak out more, though, because then it looks like it's just you and me.
So that's what I agree. I guess I'm different.
They feel the exact same way.
Yeah, they feel the exact same way. I guess I'm different than you because I've been, my entire career, at least the last 6 years, I've been, every day I get,
people yell at you. Okay. This is the first time in my life anyone has ever yelled at me.
Okay, so that's the difference.
That's right.
Yeah,
it is a difference.
I've gotten a sack of shit on my doorstep for 5 years. Okay, so my question is, how is that? How do you deal with that? How do you think about that? You're not letting it phase you. You are you're better than anyone I ever know. You never say anything mean-spirited back to anybody on Twitter. I don't know how you do it. It's like a superpower. I can't do it. I'm not as good as you. So how do you balance this? How do you think about this?
Well, okay, so there have been 2 times in this pandemic that I have actually sunk to the floor on my knees, literally. And one time was seeing what was happening in New York at the beginning, and I wanted to go there, and I felt so sad about how terrible it was in New York City. This never happened to us there. The second was one day I got it from all ends. So I got people who don't think that masks are effective yelling at me and calling me lots of names about dirty diapers on their face, and then at the same time I got someone writing and who I already muted, but said something really mean about that I had too much optimism about the vaccines, and actually made a personal slur about it in my behavior with patients. So that was the second day that I actually sank to my knees, because I thought, I am just being yelled at both sides, and I don't understand, because all I'm trying to do is keep a position that is purely based on biology, and so it just didn't seem like, and I actually don't think that, like, some of these lockdowns are merited, and so then there's a lot of biology stuff, and so I got actually very feeling terrible, and then I thought to myself, okay, one thing is that I can't look in the mirror in 2 years if I don't keep on going. If I don't, even if I'm criticized right now and people are mad at me, I can't look myself in the mirror if I don't use every biological infectious disease argument in the world to ensure that we can make teachers feel safe and try to help students get back to school. And if I don't, then I'm not doing anything right. And so I just take it, but I have to tell you that I'm very uncomfortable right now, and I cannot wait to get off Twitter. And believe me, no one will ever hear from me again in like 5 months. You'll never hear from me. No one will ever know, because I don't want to do it anymore. So I'm just going to hold it and the criticism. It's okay.
Well, somebody's knocking on your door, so our time is up. We've done this in a couple parts. I guess I just want to say, I just want to thank you for the conversation and for everything you're doing. And I guess, to many of us, you're an inspiration. And I think people who listen, I think most people will agree with the majority of what you say. There may be a few people who disagree with some of your views on some things. Natural. This happens to all of us. Monica's right. No, you're like, I'm right, but you can disagree. Yeah, that's what I tell people too. But I think you're an inspiration to many of us because you add a much needed voice to the conversation. You're brave about it. You're kind about it. You're thoughtful about it. And I literally 25, 30 people have told me how much they enjoy your tweets and they enjoyed your conversation when you came on the first time.
Thank you for having me. I really appreciate it.
No,
it was
thanks,
really
Monica.
nice to talk to you.
You've been listening to Season 3 of Plenary Session. Plenary Session is produced by Kiana Klossner. Music by Ian Straley and Audrey Tran. The views expressed on Plenary Session are those of whoever said it and no one else. Plenary Session is not medical advice. Follow us on Twitter at plenary_session. Until next time.